طيب هلا اكيد طبعا اللي بيعطي اونلاين مش زي لما بيعطي لايف. انتم مش شايفيننا ولا احنا شايفينكم، بس بنحاول تكون المحاضرة شوية واضحة وسهلة. يمكن صعب انه ندخل بكل الديتيلز لانه احنا عم نعطي 4 أو 5 محاضرات باليوم. فبنعطي الجزء الاكبر من المحاضرة والمهم تعرفوها، والباقي انتم كمان بتكملوا في البيت. هلا we will talk about thyroid disorders in pediatrics. We will cover hypothyroidism disorders and hyperthyroidism disorders. Okay, I will start talking about thyroid development, and as you all know, that fetal thyroid is bilobed in shape and start to develop at the age of 7 weeks of gestation. Then thyroxine, T4 and T3 secretion starts to be secreted at the age of 12 weeks of gestation. Following that, the thyrotropin releasing hormone, TRH, actually it starts earlier than the production of T4 and T3. It starts at the age of 6 to 8 weeks, followed by the TSH secretion at the age of 12 weeks of gestation. So at the beginning, the fetal thyroid starts at the age of 7 weeks, followed by TRH production, followed by TSH production at 12 weeks of gestation, and then T3 and T4. So just simply, you all know this picture about the pituitary gland and the hypothalamus. You all know that the hypothalamus secretes the TRH, which is the thyrotropin releasing hormone. This will stimulate the anterior pituitary to produce TSH, which is the thyroid stimulating hormone, or the thyrotropin. This actually will stimulate thyroid gland to produce both T4 and to a minimal content of T3. And we will talk that most of T3 is produced from deiodination of T4. T4 will be converted to T3, but some parts of the T4 will be converted to reverse T3, usually at the time of illness, which we call sick euthyroid. So 80% of T3 is produced by peripheral deiodination of T4, and you all should know that the T3, or that T3 is the active form, while T4 is more of a prohormone. And in the bloodstream, thyroxine binds very tightly to thyroglobulin to thyrotropin binding thyroxine binding globulin, and actually to albumin as well. T3 also binds to these proteins, but not as strongly. And you all know that the total T4 is part of it is bound, and part of it is the unbound or the free form. And only a very small fraction of T4, or the total T4 and total T3, is unbound and active. So most of it is bound and inactive. So you all know this is the thyroid histology. You all know that this is the thyroid follicle, okay? Inside the thyroid follicle, there is the colloid. And lining the thyroid follicle is the follicular cells, and those that produce the T3 and T4. And you all know this is the parafollicular cells that produce calcitonin. So what happens at birth? At birth, there is a surge of TSH that peaks by 12 hours of age. And when there is a surge, the TSH, this will be followed by rise in T4 and T3 levels, and this will peak during the first day of life and then slowly fall. Why we should know this? Should know this information because we do in Jordan and in every single country in the world what we call newborn screening tests. And we usually postpone newborn screening test after day 3, because if you do thyroid function test before day 3, the interpretation will be inaccurate because there will be a kind of surge of TSH, as we said, by 12 hours of age. In prematures, this is something different because of the immature hypothalamic pituitary thyroid axis. They will have less a kind of TSH surge. So what's the importance of thyroid hormone? You must know that thyroid hormone is very important to every single cell in the body. It increases the oxidative metabolism. It increases oxygen consumption, increases basal metabolic rate, increase glucose metabolism, and increase fat metabolism. What's the effect of thyroid hormone on growth? That's very important on growth and development. It promotes growth and development, and we will see in the following slides what hypothyroidism may cause if it occurs at birth, which is the congenital hypothyroidism. We will see stunted growth, and we will see also developmental delay. Thyroid hormones also essential for normal myelination and development of CNS. As we said, deficiency of these hormones will cause developmental delay, and also augmentation of cardiac function. In severe hypothyroidism, patient may present with heart failure. Very important. So importantly, it's very essential for normal reproductive function. And we will talk about, for example, acquired hypothyroidism. During adolescence, we will see that there will be, for example, in girls, irregular menses, for example, or oligomenorrhea. So how would we interpret thyroid function test? We usually look at the TSH first. If we see that there is a high or elevated TSH level, then we look to the thyroid, the thyroxine, sorry, the T4. If we find that there is a low T4, we will interpret as primary hypothyroidism, because low T4 there will be no negative feedback on the TSH, and it ends with high TSH. If we see high TSH with normal T4, there will be what we call compensated hypothyroidism or subclinical hypothyroidism. And actually, if we see both high TSH and high T4, we interpret as central or pituitary hyperthyroidism, which is actually rare. On the other hand, if we see low TSH, then look to for T4. If we found both are low, then this is central or pituitary hypothyroidism, which we usually see in pan-hypopituitarism. If we find that low TSH with normal T4, we call it subclinical hyperthyroidism, and that's actually not very common. And if we see high T4 with low TSH, then you know that high T4 will suppress TSH level in thyrotoxicosis or primary hyperthyroidism. So any question on this slide? This is very important for interpretation. يمكن أنا يعني إذا في حدا رافع إيده يمكن ما أقدرش أشوف. المفروض في طريقة show participants. All right. Okay. Then I suppose there are no questions. So what are the disorders of thyroid gland? So we will talk about hypothyroidism, hyperthyroidism, and thyroid storm, which is actually part of the presentation of severe hyperthyroidism. And I will cover in hypothyroidism disorders the congenital or the acquired hypothyroidism. We will talk about primary hypothyroidism versus central or pituitary hypothyroidism, or what we call also tertiary hypothyroidism if the defect in the hypothalamus. And we will speak about transient versus permanent hypothyroidism. On the other hand, the hyperthyroidism, there's what we call congenital hyperthyroidism, and the acquired, which is much more common. There is primary versus central, and there is transient versus permanent. Congenital hypothyroidism, this is very important to know in pediatrics. Actually, you will not hear about congenital hypothyroidism in the other specialties. Why we should know about congenital hypothyroidism? Because it's one of the most common preventable causes of intellectual disability, which is mental retardation. Mostly it's primary. Okay, so it's primary congenital hypothyroidism. We will rarely see central congenital hypothyroidism. And the incidence is actually 1 in 4,000, so it's not uncommon. It's more common in females. You will hear about what we call cretinism. So what's cretinism? It's the arrested physical and mental development with dystrophy of bones and soft tissues. And this is actually related to the lack of thyroid secretion at birth or congenital. In congenital hypothyroidism, you will see it's either permanent, and we will talk about what causes permanent congenital hypothyroidism, or sometimes it could be transient. It's most commonly, as we said, it's primary, so the defect in the thyroid gland itself. Secondary is much less common. Most commonly, it is non-goitrous, so you will not find goiter. However, goitrous congenital hypothyroidism is still there. So what are the risk factors for a baby to develop congenital hypothyroidism? So prematurity, as we said, the immature axis of the hypothalamic pituitary thyroid axis, or immaturity of the thyroid gland itself. Multiple gestations, you will see it's common in twins or triplets. We don't know why babies of old age mothers are at risk of congenital hypothyroidism, but it's a risk factor, and it has been reported. Asians and Hispanics are at higher risk, and Down syndrome. So it's very important to know about Down syndrome kids. They are both at risk of congenital and acquired hypothyroidism. So we usually screen for Down syndrome, and we usually follow up thyroid function test since birth or after birth. So what's the etiology? As we said, it's mainly primary. So number one is thyroid, what we call dysgenesis. It's around 90% of congenital hypothyroidism. It is due to thyroid dysgenesis. So when we talk about dysgenesis, it's either aplasia, okay, or it may be hypoplasia or ectopic location. So most commonly, it's the ectopic location. It's in around 2/3 of cases, and 1/3 of cases is thyroid aplasia. So if you think of that, whether it's goitrous or non-goitrous, the defect in thyroid gland, and it's either hypoplastic, aplastic, or ectopic, so it's going to be non-goitrous congenital hypothyroidism. There are some genetic factors that may influence the development of thyroid dysgenesis, and it's usually sporadic. So you will hear patients in the clinic saying that there are no family history of such a disease because it's mainly, or usually, it is sporadic. The second main etiology of congenital hypothyroidism, you will hear about the TRAB, which is thyrotropin releasing thyrotropin receptor blocking antibody. You will hear about thyrotropin receptor stimulating antibody, and you will hear about thyrotropin receptor blocking antibody. you all know that the stimulating antibody is much more common, but if the mother has a thyrotropin receptor blocking antibody, then it will cross the placenta and it will end in congenital hypothyroidism in the newborn. However, it is transient. So sometimes it will remit in 3 months, in about 3 months, maybe earlier. So this is transient. Other causes of congenital hypothyroidism, we will talk about mothers who are on anti-thyroid medications. For example, Gravis disease mothers who had TRAP, which is a stimulating antibody. However, they are on anti-thyroid medication. This will or may end in congenital hypothyroidism, which is likely transient in the newborn. The third etiology is what we call thyroid dyshormonogenesis. So from the name, dyshormonogenesis, so there is an abnormality in the metabolism, intrathyroid metabolism. It's usually goitrous or almost always goitrous. I will put for you a slide about the intrathyroid metabolism. How is the uptake of the iodine from the follicular cells, and what happens intrathyroidal until the release of free T4 and the T4 and the T3. Any defect in the steps in the intrathyroid metabolism will end in what we call congenital hypothyroidism, which is almost always goitrous, except if the defect is at the beginning of the metabolism of the hormones. It may be non-goitrous. Actually, it's rare, as reported, but in our country, because of the consanguineous marriage, we see a lot of thyroid dyshormonogenesis. So this one is actually like inherited, in opposite to the thyroid dysgenesis, which is usually sporadic. So what are the clinical manifestations? Usually they are asymptomatic. So you'll see infants at birth are usually asymptomatic because they are mainly dependent on thyroid hormones from the mothers. Also, although it's reported that thyroid hormones are partially crossing the placenta, but usually they are, or almost always they are asymptomatic at birth, and symptoms start to develop after birth. Usually the growth parameters are normal. Sometimes we may see that the head size may be slightly increased. And usually the symptoms start to develop weeks or months later. If severe congenital hypothyroidism is there, then symptoms starts earlier. You must all know that there is neonatal screening in Jordan and in all the countries of the world, in all of the world countries, and it is very crucial for early diagnosis, because as early as you treat with thyroxine, the less the complications. Some kids may, or some newborns may, or some pregnancies may be post-date, more than 42 weeks. Sometimes we may find kids or newborns with large for gestational age, more than 4 kilograms. Some newborns may develop hypothermia or acrocyanosis. Some of them may present with respiratory distress. When you examine them, you may find large posterior fontanelle and anterior fontanelle, but the posterior fontanelle is characteristic of congenital hypothyroidism. So examine the fontanelles. Sometimes you may see like abdominal distension, and it's characteristic to find umbilical hernia. The main presentation when they develop after 3 or 4 weeks of age, you will see they present with poor feeding and lethargy. Very important to know about prolonged jaundice. for example, newborns after 2 weeks of age, they retain what we call jaundice. And you know the definition. I'm not sure if you have already exposed to jaundice, but prolonged jaundice is defined as jaundice after 2 weeks of age that continues. And if you find any newborn or neonate with prolonged jaundice, you must exclude congenital hypothyroidism. Some may develop myxedema or edema, umbilical hernia, as we said, mottled skin. تعرف شو يعني mottled skin؟ حدا بيعرف؟ طبعا mottled skin إذا بتطلعوا على السكين بيكون زي كيف like web، like زي الشبكة يعني بيكون شكله. Constipation, dry skin and hoarse cry. تيجي بتحكي لك الأم إنه مش عم بكاءه بيختلف مثلا عن بكاء إخوانه لما كانوا صغار. عنده زي hoarse cry, weak cry, or cry little and sleep much. This is actually a picture of a newborn or a neonate with congenital hypothyroidism, because a newborn, as we said in the first or at birth, they are asymptomatic. This is actually after 1 to 2 months of age. So you will see that there is protruded tongue. This is characteristic of congenital hypothyroidism. You will see the low hairline, if you can see here. So they have low hairline, protruded tongue, okay? If you concentrate, you will find what we call mottling in the skin. زي هيك زي الشبكة شكله هون. You will see the umbilical hernia, okay? So these are the characteristics of congenital hypothyroidism you must look for on physical examination. If the patient is untreated or misdiagnosed, then by the age of 3 to 6 months, the clinical picture is fully developed. You will see that the patient will have stunted growth, short extremities, normal or increased head size, with open posterior fontanelle, because the posterior fontanelle usually closes by the age of 2 to 3 months. However, if there is untreated congenital hypothyroidism, the posterior fontanelle will remain open. As we said, more large protruded tongue, delayed dentition, بتأخروا لبين ما يسننوا بنسميهم. ويكون في عنا short and thick neck. Broad hands, short fingers, dry skin, myxedema, and brittle and scanty hair on the scalp. And as we said, low hairline. It's very important to mention brain maturation and development. So any patient who has developmental delay, maybe hypotonia, developmental delay in the motor or the cognitive function, you must think of hypothyroidism. If you do what we call bone age, which is the X-ray of the wrist and the left wrist and hand, you will find what we call delayed bone age. So we usually do left wrist and hand X-ray. However, in the newborns or the first 6 months of life, we may do what we call knee X-ray. So there will be delay in the ossification of the distal femur or proximal tibia. So how do we diagnose congenital hypothyroidism? So as we said, screening programs are very essential and important. You must all know that we do that from the heel stick, like on a filter paper. راح أحط لكم slide عن filter paper and how we do heel stick blood drops. Then we send it to the lab. They usually screen for high TSH. So if you find high TSH more than 100 milli-unit per liter, this is characteristic of congenital hypothyroidism. And if you do full thyroid function test, you will have low T3 and T4.
دكتورة ممكن سؤال؟
تفضلي.
هلا احنا نحتاج نعمل هذا السكرين أول ما ينولد ولا في فترة معينة؟
تمام. هلا زي ما اتفقنا انه at birth there is a TSH surge, right? عشان هيك قلنا it's inaccurate to do the screening test in the first 3 days of life. هلا عادة السكرينينج ما بين يعني بعد اليوم الثالث but as early as possible. هلا أنا لاحظت هون في المراكز الصحية بيقولوا للأم روحي وارجعي على الأسبوعين عشان تاخذ البي سي جي تست، البي سي جي فاكسين، ويعملوا الهيل ستيك تيست. هلا 2 weeks أنا بالنسبة لي بعتبرها it's delayed. فأنا بفضل عادة إنه الهيل ستيك تيست ينعمل بعد اليوم الثالث خلال الأسبوع الأول but not before day 3. تمام؟ أوكي؟
احنا تقريبا معنا للثلاث شهور لنعمل الفحص، يعني قبل الثلاث. بعرف انه بزيد يعني الريسك، بس انه قبل 3 شهور، ولا من متى عن جد ببلش انه اوكي انت عم تتأخر جد؟ من 3 شهور ولا من بعد اسبوعين؟
هلا the earliest the treatment the better the outcome. هلا 3 شهور أنا بالنسبة لي this is delayed treatment. فكل ما بكرنا وكل ما عملنا التست أبكر كل ما كان ال long term outcome especially the cognitive function is better. والاي كيو تيست رح نحكي كمان شوي عن الاي كيو. ف 3 months انك تشخصي congenital hypothyroidism على 3 months is delayed. So كل ما بلشت التريتمنت قبل الشهرين كل ما كان better.
تمام، شكرا دكتور.
اوكي بس 3 months متأخر. اوكي 3 months متأخر. هلا عادة so when you do thyroid function and you find high TSH treat as soon as possible. هلا بدول برا بيعملوا what we call بالسلايد هون thyroid scan. فعادة مجرد ما شافوا high TSH level then they do thyroid scan using technetium. And this will diagnose it's either thyroid aplasia, hypoplasia, or ectopic thyroid gland. Usually it's lingual thyroid gland. It's usually lingual. بس عندنا هون ما بنعمل thyroid scan. It's not common to do thyroid scan, so we treat as soon as possible. خلص شخصنا hypothyroidism، خلص we start thyroxine. okay. هلا later on هلا شو ممكن نعمل؟ ممكن نعمل thyroid ultrasound. بس انك تعمل thyroid ultrasound during infancy it's not very accurate. ليش؟ It's operator dependent. It's not easy because they have short necks, so it's not easy to do thyroid ultrasound during the first year of life. فعادة احنا ما بنستعجل عليها. يعني مش كتير انا مهتمة what's the underlying etiology. المهم اني اعالج. اوكي هلا later on بعد السنة وسنتين وثلاث سنين بحب اعمل thyroid scan، بحب اعمل thyroid ultrasound، وقتها بنعمله وبنشخص. اوكي بس طبعا الثايرويد سكان صعب اني اعمله قبل العمر الثلاث سنين. ليش؟ حدا بيعرف؟ حدا بيعرف الثايرويد سكان في له سبيشال prerequisite او سبيشال criteria عشان اعمله. هلا الثايرويد سكان it's accurate when you have a very high TSH. فانت بدك تيجي تبلش ثايروكسين وبعدين يصير المريض ثايرويد، بعدين تيجي تعمل ثايرويد سكان ما راح يعطيك good results. اوكي فدائما بدك تعمل ثايرويد سكان لازم يكون القاعده الذهبيه اللي بنسميها الجولدن رول انه يكون في عندي high TSH level to stimulate the uptake. اوكي هلا انا المريض ما دام بلشته ثايروكسين انا ما بقدر اعمل ثايرويد سكان. هلا في بعض الجايد لاينز والريكومنديشنز بعد عمر الثلاث سنين after the brain maturity it's almost خلينا نقول بدناش نقول ended يعني، بس بعد ما نتعدى اللي هي المرحله الذهبيه بالبرين ديفلوبمنت اللي هي اول 3 سنين بيجيبوا وقف الثايروكسين. when they have high TSH level they do thyroid scan and they can diagnose whether it's dyshormonogenesis or ectopic thyroid gland. هلا عندنا هون زي ما قلت لكم ما بنعمل thyroid scan ويجوا start treatment. ممكن نعمل later on thyroid ultrasound، ممكن نعمل thyroglobulin because if you detect thyroglobulin which is the main material found in the thyroid colloid, if you detect thyroglobulin, so this is unlikely to be thyroid agenesis or hypoplasia. طبعا الاذرز skull x-ray we don't use it we don't do it frequently. But if you do skull X-ray, you may find large fontanelle, white suture, worm in bones, etc. And if you do ECG, you will have low voltage ECG. Okay, but usually we don't do ECG frequently. So you do thyroid function test, maybe thyroglobulin, and then you start treatment as soon as possible. Quickly about screening strategies. So we have 3 major screening strategies. هلا في بعض الدول بتيجي بتقول بدنا نعمل بس TSH level. في بعض الدول بتيجي بتقول لا بدنا نعمل بس T4 level. يعني الدول اللي بتعمل بس TSH level زينا احنا هون، إذا بتلاقي high TSH this is congenital hypothyroidism، بعدين نجي بنعمل full thyroid function test بنشوف T4. هلا بعض الدول بتيجي بتعمل T4، إذا لقوا low T4 بيجوا بيكملوا بيعملوا TSH لهداك النيو بورن. اوكي. وفي بعض الدول بتعمل full thyroid function test. هلا وجدوا اذا بتعمل TSH you may خلينا نقول under diagnose some of the conditions زي central hypothyroidism which is uncommon. واذا بتعمل T4 وبتلاقي normal you may under diagnose subclinical hypothyroidism. اوكي. مش راح نحكي عن هذا كله، بتقرأوا انتوا لحالكم، بس زي ما قلت لكم انه if you do one of them you may underdiagnose the other. وجدوا اذا بتعمل full thyroid function test you may overdiagnose. اوكي. بس it depends on the country. احنا هون بنعمل TSH level. هلا مثلا بالمستشفيات الثانيه مثلا بالقطاع الخاص او بالمستشفيات الجامعيه نحن بنعمل full thyroid function test. اوكي. بس وزاره الصحه بتعمل اللي هو الهيلستيك وبتعمل TSH level. If they find high TSH level they call the parents to come back to endocrinologist and repeat thyroid function. Okay. And what's the treatment for hypothyroidism? It's thyroxine. مش مطلوب منكم تحفظوا الدوزز. But we start with a high dose of levothyroxine. طبعا مهم كتير تعرفوا عادة levothyroxine it's preferred to be given in the morning and it's preferred to be away from the meal around minimum half to 1 hour because thyroxine is influenced and its absorption is influenced by the type of food. So if it's taken with meal then the absorption of thyroxine may be reduced. Okay, especially with soy protein. إذا مثلا في أطفال ماشيين على الصويا ميلك for example، أو إذا في أطفال بياخدوا ايرون، دائما بنحكي للأهل do not mix with soy milk or iron. يعني عادة يكون في تباعد، الطفل اللي ماشي على ايرون ياخذ الايرون مثلا المساء والثايروكسين الصبح. هلا في بعض الامهات بتقول لك ما اقدر والبيبي ضل يبكي وبدي ارضعه دايركت، بنقولها انه ياخذ ويرضع دايركت ذاتس فاين، بس اذا بنقدر يكون في مسافه ما بين الثايروكسين تابلت وما بين الميل اتس ماتش بيتر. اوكي. حتى بالادلتس دائما بيقولوا اذا اخذته طبعا بالباطني بيقولوا لك انه دائما تاخذ الثايروكسين الصبح بيكون في تقريبا ساعه عن البريكفاست او حتى عن البريفيوس ميلز. طبعا رح تسالونا كيف. طبعا عاده ما في سيرم ما في سيرب للثايروكسين، فيجوا لي بنقول لهم جيبوا التابلت و you may dilute it with water or with milk. Okay. So here the prognosis is very important. So there is inverse relationship between the age at diagnosis. هاي الدكتورة اللي سألت. So there is inverse relationship between age at diagnosis and treatment initiation and the IQ test later in life. So the longer the condition goes undetected, the lower the IQ. كل ما تأخرنا بالتشخيص كل ما كان cognitive function worse. Okay. So usually they found that it's reported that بالstudies if treatment is initiated within the first month, okay, the prognosis is excellent. إذا الدكتورة اللي سألت على 3 شهور is considered a little bit delayed. طبعا if diagnosis is done after the age of 6 months it's very bad for the intellectual development. ف later on كيف ببين عليهم مثلا بالمدرسة ممكن يجوا عندهم poor school performance and low IQ. بقول لك بالمدرسة ما بيستوعب كتير، ما بيركز كتير، بالرياضيات مش كتير شاطر، ما الحفظ عنده بطيء، التعلم عنده بطيء، فبنسميها learning disabilities and poor intellectual development. هلا الجروث it's usually affected but after the commencement of thyroxine growth will improve even in late cases. So the major thing that is influenced but will not improve if late diagnosis happened is the intellectual development. Okay. هلا some cases of congenital hypothyroidism, the mild cases, the onset may present after the age of 2 years of life. Usually they have normal development because you know the CNS development occurs in the first 2 to 3 years of life. Okay, فهدول طبعا بنسميهم lucky patients انه ال mild cases development after the age of 2 years. The presentation of hypothyroidism after the age of 2 years. So already the normal development already happened. So we will monitor growth then. We usually ask if breastfeeding is adequate to protect an infant with congenital hypothyroidism, and the answer is no. So breastfeeding is not adequate to protect an infant with congenital hypothyroidism if no thyroxine commenced or started. And breastfeeding, usually parents ask us whether breastfeeding influence thyroid screening test, and we said no. So it has no effect on thyroid screening test. لحد هلا في حدا عنده سؤال؟ Any questions؟ حدا عنده سؤال عن الكونجنتال هايبوثايرودزم؟ يعني عادة الكونجنتال هايبوثايرودزم عليها كتير أسئلة، يعني إما بالميني أوسكي إما بالريتن، فيعني توقعوا كل سنة يكون في سؤال بالفاينل، سؤال سؤالين 3 أسئلة ما بنعرف عن الكونجنتال هايبوثايرودزم. This is very important. ما رح تاخدوه بأي مكان تاني. أوكي؟ ما رح تاخدوه لا بالباطني ولا بالجراحة ولا بأي مكان. أوكي؟ أي سؤال؟ بدي افترض انه ما فيه. طيب بدنا ننتقل للاكويرد هايبوثايرودزم. اوكي تفضلي تفضلي، صوتك بيقطع. تحكي كمان مره لانه ما سمعناكي.
بسأل اللي ناخذ عينة الدم من كعب الإجر.
اوكي ايش السؤال؟ انه متى بناخذ؟ ما
نسحب من كعب الإجر.
دكتورة صوتك بيقطع. هلا سؤالك متى بتتاخذ العينة من كعب الرجل نفسها، هيك سؤالك؟
لا ليه ناخذها من هذاك المكان بالضبط؟
هلا لو بتعرفي لهذيك المنطقة بالنيو بورنز is highly vascularized. اوكي، فانك اسهل تاخذي من كعب الرجل للطفل من اي محل تاني يعني. اوكي، فإتس highly vascularized وما بيكون السكين ثيك زي ما بصير اللي هي بالادلتس. اوكي، واتس فيري ايزي، يعني رح تشوفي لما بتداومي خداج او شفتوا بالخداج او شفتوا بالنيو بورنز بالنيرسريز، حتى الفحوصات الثانيه زي الجلوكو تشيكس مثلا او مثلا البلد جازز عاده بناخذهم بالهيل ستيك لان اتس هايلي فاسكولارايزد. اوكي، بس مش غلط انها تتاخذ من اي محل ثاني. يعني تخيلي بتاخذيه من اصبعه، قديش اصبع بيكون كتير صغير، فصعب تتاخذ من الاصبع، بس يعني عادي مش غلط يعني. بس هذا السؤال. طيب نحكي عن الاكويد هايبوثايرودزم. طبعا البيج اكزامبل او على الاكويد هايبوثايرودزم اللي هو هاشيموتو's hypothyroidism. Okay, which is the lymphocytic thyroiditis, which is the most common cause of acquired hypothyroidism. Okay. طبعا لازم تعرفوا انه في شيء بنسميه autoimmune polyglandular syndrome، رح نحكي عنه كمان شوي. Which is multiple autoimmune disorders in multiple glands. راح تشوفوا there's acquired hypothyroidism very characteristic in Down syndrome, in Turner and in Klinefelter syndromes. Okay, so those are at risk of acquired hypothyroidism. Okay, which actually most commonly it is the Hashimoto's thyroiditis. Okay. Some patients following subtotal thyroidectomy, okay, or total thyroidectomy, they will have what we call acquired hypothyroidism. For example, patients who have Gravis disease, uncontrolled on antithyroid medications, and they end up with total or subtotal thyroidectomy, and then hypothyroidism. There is what we call histiocytic infiltration of the thyroid gland. So histiocytosis, for example, Langerhans cell histiocytosis, there is histiocytic infiltration in the thyroid and in the other glands, such as the pituitary gland. So they may have acquired hypothyroidism. Irradiation, for example, neck irradiation. So patients who have, for example, spinal tumors and ended up with neck irradiation, they will have acquired or may have acquired hypothyroidism. And don't forget amiodarone. So amiodarone is one of the cardiac drugs. فبتعرفوا الاميودارون تاخذوه اللي عندهم ECG abnormalities أو rhythm abnormalities. فمرضى بتلاقيهم ماشيين على الاميودارون, they will have acquired hypothyroidism. So it's very important to ask in the history whether the patient is on any medications or has been exposed to any irradiation, and definitely if they look syndromatic on physical examination. Okay. طبعا كلكم بتعرفوا what are the clinical manifestations of hypothyroidism. This is very important. طبعا انت يمكن بالدام ووردز فما بتشوفوا الهايبوثايرويدزم patients والمانيفستيشنز تبعتهم, بس اذا اجيتوا على الاندوكراني كلينيك راح تشوفوا much more common. اوكي. كتير مهم تتذكروا الستانتينج. يعني كتير بيجونا أطفال they only complain of short stature. يعني هديك المرة إجاني طفل على العيادة وعمره 9 سنوات و he has been stunted. يعني بتقول الأم صار له 6 شهور ولا سنة مش عم يطول ولا سنتي. أوكي. هلا part of screening for short stature to do a thyroid function test. فطلع المريض عنده primary أو اللي هو Hashimoto's Thyroiditis. So once you start thyroxine, growth will improve directly. Myxedema definitely. كلكم بتعرفوا هدول common symptoms, حتى بتسمعوهم كمان في الباطني, constipation, cold intolerance. كلكم بتعرفوا إنه زي ما اتفقنا قبل شوي the importance of thyroxine to increase the basal metabolic rate. فالمريض اللي عنده hypothyroxinemia he will have reduced basal metabolic rates, صار يصير عنده cold intolerance, decreased energy and concentration, increase the need for sleep and delayed osseous maturation. إذا بنعمل لهم bone age x-ray راح نلاقي إنه عندهم what we call delayed bone age. يمكن ما بعرف إذا أخذتوا داومتوا orthopedics ولا لسه؟ حدا بيحب يجاوبني؟
لا لسه.
لسه. فإشي بنسميه البون ايج. البون ايج we do what we call wrist and hand x-ray, usually left side. We compare the osseous centers, وفي بيكون عندنا أطلس يعني زي كتاب بنقارن فيه the ossification centers مع الكتاب اللي معنا, بيعطينا انه والله البون ايج مثلا 3 years 4 years 6 years. فبنقارنه مع الكرونولوجيكال ايج. يعني طفل عمره 10 سنين عملنا له بون ايج اكس راي طلعت 7 سنين. اوكي. فبنسميها delayed bone age in comparison to the chronological age. فبس تداوموا اورثو اكيد رح يحكوا عنها, ولما بتداوموا السنه الجاي بيدياتريكس كمان بنحكي عنها في سيمينار short stature. Sometimes they may present with delayed puberty and sometimes with precocious puberty. Okay. This is very important. في كتير بيجونا بنات في عندهم symptoms of precocious puberty. Precocious puberty هلا رح نحكي عنها in 1 or 2 hours, اللي هي ال early onset of secondary sexual characteristics. Okay. هلا ليش؟ هلا رح نحكي عنها أكتر. إنه المرضى اللي عندهم primary hypothyroidism بيكون عندهم ال TSH is high. هلا ال TSH وال FSH share one of the subunits. ففي عندهم one of the subunits are the same. So they high TSH mimic high FSH, so they end up with premature or precocious puberty. And some patients may have delayed puberty. وإذا طبعا كان في عندنا الجيرلز post menarche, ولا رح نحكي شو يعني menarche اللي هي first menstrual period. So after menarche, they may have what we call oligomenorrhea irregular periods. Okay. دوامته نسائية طيب؟ برضه لا. اوكي طيب. Oligomenorrhea اللي هي decrease frequently of menstrual periods. اوكي. هاي رح نحكي عنها بعدين انه after the commencement of treatment يعني مجرد ما بلشنا ثايروكسين لمريض hypothyroid we must start gradually. Okay, عكس بالneonatal period. هلا بالneonatal period the congenital hypothyroidism usually we start with a higher dose, but in acquired hypothyroidism we start increasing the dose gradually. We start with a minimal dose and increase the dose gradually, because they found that if you normalize thyroid function test quickly, then this will end in like كيف انك مريض متعود على hypothyroidism وتعطيه فجأة ثايروكسين زي كأنه بصير عنده hyperthyroidism symptoms، فبصير عندهم deterioration in schoolwork, poor sleeping habit، رح يصير عندهم decreased sleeping, restlessness, short attention span and behavioral problems. عشان هيك دائما بنقول انه when you treat hypothyroidism you treat it gradually. Okay. ولازم تعرفوا دائما انه when you treat hypothyroidism, you look for the thyroid function test after, for example, 1 month. So TSH needs to be normalized in about 4 weeks. Okay. يعني على فرض انت بلشت الثايروكسين هلا وبعدين بعد بأسبوع الثايرويد function test, you'll find mildly decrement in TSH. فما راح TSH will not normalize in 1 week. It needs actually around 4 weeks to normalize. So Hashimoto's thyroiditis, so بيسموها autoimmune or lymphocytic thyroiditis. And you should note that it's the most common cause of goiter and hypothyroidism in older children and adolescents. And sometimes it may present with hypothyroidism without goiter. Okay. فإذا شفنا for example female girl عمرها 11 سنة جاية عندها goiter, it's almost always Hashimoto's thyroiditis or lymphocytic thyroiditis until proven otherwise. It's the incidence is 1%, so it's considered common. Usually إذا سألتوا بالhistory رح تلاقوا فيه positive family history in around 1/4 of cases. فإذا لقيتوا في positive family history, this may suggest there is a genetic predisposition. Okay. طبعا الباثوفيزيولوجي من اسمها lymphocytic thyroiditis, so it's lymphocytic infiltration of T cells and B cells to the thyroid gland, which lead to thyroid gland destruction. What are the antibodies that we usually screen or diagnose lymphocytic thyroiditis؟ هدول لازم تحفظوهم، هدول تنسألوا عنهم كتير. فبنسميه anti-TPO أو الثايرويد peroxidase antibodies. Okay, anti-TPO أو بنسميهم antimicrosomal antibodies. وin pediatric age group they are much more common than the other type of antibody, which is antithyroglobulin. Okay, which is much more common in adults. فإن 90% of cases anti-TPO antibody is positive. فلما نقول لكم شو الانتيبوديز للليمفوسيتيك ثايرويدايتس بتقولوا لي انتي تي بي او، انتي مايكروزومال اور انتي ثايروجلوبولين. مثلا باللوبس شو كنتوا تقولوا الانتيبوديز؟ حدا بيعرف؟ مين اسال اختار بالاسم؟ شو يا عزات باللوبس؟
في عندنا انتي دي ان وانتي سميث.
مزبوط
فوسفوليبيدز.
صح. اذا انتي نيوكلير انتي بوديز، انتي فوسفوليبيد انتي بوديز، انتي سميث انتي دي ان ايز انتي دي ان اي انتي بوديز. اوكي. هلا بالاوتو اميون هيباتايتس رح تاخذوا الاسبوع الجاي في مثلا انتي ماسل برين كيدني انتي بوديز. بالهاشيموتو تتذكروا الانتي ثايروجلوبولين والثايرويد بيروكسيديز انتي بوديز. اوكي. طبعا تذكروا الهاشيموتو ثايرويدايتس much more common in girls. هلا بنشوفها in both boys and girls، بس راح تشوفي it's much more common in girls as the other autoimmune disorders. Okay. There is a peak in adolescent. Okay. Adolescent period. The most common presentations زي ما قلت لكم growth retardation، كتير بيجينا بشورت ستاتشر على العيادة وبنشخصهم hypothyroidism. او الاذر مانيفستيشن يجوني بجويتر، فبيجوا الاهل بيقولوا لك دكتوره هيك رقبتها نافخه، بتطلع عليها بتفحصها بتلاقي الثايرويد جلاند بالبابل. اوكي. طبعا description of goiter إذا فحصنا مريضة with goiter related to Hashimoto's thyroiditis, it's usually diffuse. It's not multinodular. It's usually diffuse. It's firm and non-tender. Okay, non-tender. Okay. And patients with Hashimoto's thyroiditis, for example, if they present with goiter, initially they may be euthyroid. يعني بتعمل thyroid function test بيكون عنده goiter، تعمل thyroid function test بتكون normal. Or may present with both goiter and hypothyroidism. Other rare presentation بنسميه hyperthyroidism with goiter, but it's mainly transient because of the initial destruction of the thyroid gland. It may begin as hyperthyroidism، حتى بنسميها Hashimotosis إذا سمعتوا فيها Hashimotosis. So usually starts as hyperthyroidism, which is usually transient, then ends up with EO or hypothyroidism. هلا sometimes if the patient present with hyperthyroidism طبعا انت بتفكر بتقول most common cause رح نحكي عنه كمان شوي اللي هو Gravis disease حتى زي ما اخذته بالباطني. بس اذا عملتوا الانتيبوديز فور Gravis disease والانتيبوديز فور هاشيموتوز ممكن يكون في overlap، فبتلاقي المريض عنده تراب بوزيتيف Gravis بوزيتيف. اوكي. بس اذا بتعمل له انتيبوديز فور هاشيموتوز ممكن تلاقي انتي تي بي او انتي ثايروجلوبولين antibodies are positive as well. حتى الophthalmopathies they may occur but less common in pediatrics. Okay. هلا رح تسألونا what's the clinical course of acquired hypothyroidism. هلا زي ما قلنا ال presentations are either goiter, either stunting or short stature or poor growth. Much less common انهم يجوا ب hypothyroidism symptoms. اوكي. انه الاهل ينتبهوا انه عنده constipation او cold intolerance او etc. Later on what may happen, the goiter may get smaller, may disappear or may persist or may become larger. Okay. هلا euthyroid patient may continue the same أو طبعا ال patients may develop hypothyroidism later on. And you must know that Hashimoto's thyroiditis may be associated with other autoimmune disorders زي type 1 diabetes. خاصة مرضى type 1 diabetes رح نحكي بمحاضرة اليوم. They are at risk to developing other autoimmune disorders such as Hashimoto's thyroiditis. فإحنا مرضى diabetes we screen for them annually or every second year with TFT اللي هي thyroid function test and thyroid antibodies اللي حكيناهم قبل شوي. Hashimoto's may be associated with adrenal insufficiency, which is sorry, this is one S rather than double S, which is Addison disease and hypoparathyroidism. عشان هيك في إشي بنسميه autoimmune polyglandular syndrome type 1 وفي type 2. هلا ال type 1 بيكون عندهم المرضى mainly hypoparathyroidism and Addison disease، يعني بيجوا mainly بأدرينال adrenal insufficiency. May have hypoparathyroidism, may present with hypocalcemia. Mucocutaneous candidiasis is characteristic and may be associated with hypothyroidism in 10% of cases. هلا في type 2 طبعا الإشي المشترك بينهم اللي هو Addison disease adrenal insufficiency. Type 2 بيجوا بأدرينال insufficiency, type 1 diabetes and frequently hypothyroidism. Okay. It's mainly genetic predisposition. Other associations طبعا في عنا ممكن pernicious anemia. Okay. ممكن vitiligo, alopecia. There is an association with congenital rubella and we don't know why. Trisomies زي trisomy 21 and Turner syndrome they are at risk of Hashimoto's thyroiditis. عشان هيك مرضى التريسومي 21 Down syndrome وتيرنر syndrome we screen for thyroiditis in those patients. فمرضى التيرنر we do every year or every second year thyroid function at the same in trisomy 21. طبعا trisomy 21 may have both congenital hypothyroidism or acquired زي ما اتفقنا. Alternate usually they have acquired hypothyroidism اللي هو الautoimmune أو اللي هو الهاشيموتو's thyroiditis. How would you diagnose؟ طبعا definitely clinical presentation is either goiter or stunted growth. We do thyroid function test. Usually you will have high TSH, okay, with low T4. طبعا إذا شفنا normal T4 بنسميها subclinical hypothyroidism زي ما حكينا بالسلايدز الأولى. If you send antibodies, you may have positive antibodies. طبعا this is enough for diagnosis of Hashimoto's thyroiditis. في ناس بيقولوا تعالوا نعمل thyroid ultrasound, which may just baseline أنا بعمله صراحة. You may have طبعا heterogeneous gland with scattered hypoechogenicity and increased vascularization. أنا بعمله baseline لأنه later on we will follow up with thyroid ultrasound because you know such patients are at risk of developing thyroid cancer or malignancy, okay? طبعا in minimal percentage of cases. طبعا thyroid scan برضه ممكن ينعمل. والديفينيتيف عشان نقول this is Hashimoto's thyroiditis أو lymphocytic thyroiditis biopsy. However, we don't do biopsy, we don't do scan or even ultrasound. So they are not indicated at all. فإذا بنسألكم كيف بنشخص thyroid function test and thyroid antibodies are enough for diagnosis. Okay, we don't do the others at all. Maybe thyroid ultrasound, but not the others. And treatment is زي ما اتفقنا levothyroxine, okay? Gradually, especially if the patient has been chronically hypothyroid. فإذا المريض chronically hypothyroid, you must start gradually or with a minimal dose. And we follow up these patients. هلا إذا المريض إجاني euthyroidism, we usually we keep following the patient every 6 to 12 months or even earlier with serial thyroid function test, and we usually counsel the patients whenever you have hypothyroidism symptoms, and we tell them what are the hypothyroidism symptoms, come back earlier to check thyroid function. In some cases of euthyroidism, we may start thyroxine, but it has special indications such as severe goiter that interferes with swallowing. So if we have a large goiter that interferes with the swallowing, for example, or may have neck symptoms, even if the patient is euthyroid, you may start thyroxine. But طبعا you have to refer him to endocrinologist before. فزي ما اتفقنا goiter with normal TSH or with euthyroid status, usually there is no treatment, but it's controversial whether to start or not. It depends on specific indications. Subclinical hypothyroidism, برضو there is a controversy whether to start or not. Usually we don't start thyroxine and we keep following the patients every 3 months. Except if there are special indications, for example, symptomatic patients. Some patients with subclinical hypothyroidism, we think it's mainly asymptomatic, but some patients may present with symptoms. So if they are symptomatic with, for example, large goiter, you may start treatment. لحد هلا في حدا عنده أي سؤال عن acquired hypothyroidism؟ متأكدين؟ انتوا صاحيين معي ولا نايمين؟ شكلكم نايمين. طيب وين عبد الرحمن خلدون؟ طبعا اللي بسأله وما برد علي راح احطه غياب. وين عبد الرحمن خلدون؟ اللي بسأله ما برد علي راح احطه غياب، ما يرجع علي بعدين يقول لي هياتني هون وكان المايك خربان. طيب عبد الرحمن خلدون غياب حتى لو انه اونلاين. وين اجياء لا سوري وين آفاق عبد الرحيم،
نعم دكتور.
ايش هم الانتي بوديز للاكويات هايبوثايرويدزم؟ حضرتي معانا آفاق؟ هلو.
يس دكتور.
شو هم الانتي بوديز؟ بس علي صوتك شوي. ايش هم الانتي بوديز للهاشيموتو's ثايرويدايتس؟ شو نبعت عادة؟ دكتورة انت حضرتي معانا؟
دكتور
طيب شو هم الانتي بوديز؟
هم الانتي ثايرويد انتي تي
اوكي.
انتي ثايروجلوبين.
اوكي ماشي يا آفاق. طيب وين عمار؟
نعم دكتور.
طيب عمار، what's the most common cause of congenital hypothyroidism؟ أعطيك خيارات. ثايرويد ديسجن تفضل.
يا ريت
يا ريت أعطيك خيارات. طيب حلو. ثايرويد ديسجينيسيس ولا ديسهرمونوجينيسيس ولا due to antibodies maternal antibodies؟
ثايرويد ديسجينيس.
ديسجينيسيس. ايش الموست common cause of thyroid dysgenesis؟ hypoplasia, aplasia ولا ectopic thyroid gland؟
مش عارف صراحة.
معناته مش مركزين، معناته ولا واحد، أنا بحكي لحالي شكلي.
الإكتوبيك أتوقع.
طبعا بتتوقع؟ لا هو مش تتوقع، ectopic. طيب وين أيمن؟ أيمن محمد ماجد. قلت لكم البنات عليه غياب، هيك الحضور الغياب أنا عندي. وين أيمن؟ أيمن محمد ماجد. أيمن محمد ماجد آخر نداء. طيب أيمن محمد ماجد غياب. وين فهد؟
موجود دكتور.
أعطيني الريسك فاكتورز to develop Hashimoto's thyroiditis. مين هم الناس اللي at higher risk؟
مش عارف دكتور.
أعطيك خيارات؟
اوكي.
طيب تيرنر، داون، adolescent female، type 1 diabetes patients. مين هم أكثر ناس higher risk to develop Hashimoto's؟
مش عارف صراحة دكتور.
يعني بدك تقول لي ما فيش خيار اسمه all the above؟
ممكن.
ممكن. يعني صار لي ساعة بح صوتي وأنا بحكي إنه الهاشيموتوز thyroiditis at higher risk to develop other autoimmune disorders، وحكينا فيهم بيجي 10 وبرضه بتقول لي ممكن. معناته انتوا ما بتحضروش، يعني انتوا بس فاتحين اللابتوبات هيك كذب. وين مين كمان؟ عمرو؟ في عمرو؟ وين عمرو؟ عمرو باسم عارف الطراونة. وين عمرو الطراونة؟ عمرو الطراونة آخر نداء. عمرو الطراونة. طيب أوكي غياب. طيب مش رح نضيع وقتنا بالحضور والغياب. بس مبين عليكم يعني 3/4 مش حاضر. anyway hyperthyroidism، خلينا نحكي عن hyperthyroidism. اوكي so hyperthyroidism معناته excessive secretion of thyroxine. اوكي The most common cause is Gravis. لما بنقول hyperthyroidism, it's mainly due to Graves disease, okay? Which is diffuse thyroid hyperplasia, okay? هلا في other causes of hyper طبعا Gravis it's an autoimmune. It's mainly caused by TRAP اللي هو thyrotropin receptor stimulating or طبعا blocking antibody, but it's mainly been in Graves disease stimulating antibody that stimulate the thyroid gland. So it's an immune mediated disorder. هلا في عندنا non immune mediated disorders. Yes, في عندنا المكون Albright, واقرأوا عن المكون Albright بيكون عندهم mutation, okay, in the TSH receptor, which leads to it's an activating mutation in the TSH receptor. فبصير عندهم hyperthyroidism, but it's not non-immune. طبعا النودولار goiter, وطبعا السنترال زي اللي بيكون عندهم مثلا pituitary tumors that secretes TSH, which is uncommon. Okay, عادة the pituitary tumors that secrete hormones usually prolactinomas, but some of them may secrete TSH, but it's not common. فحكينا عن التراب، اوكي، اللي هو thyrotropin receptor stimulating antibody بنسميه تراب، اوكي. It's usually associated with طبعا the genetic background HLA-B8 and DR3. وفي عنا طبعا other associations with other autoimmune disorders بيشبه طبعا Hashimoto's thyroiditis. Okay. طبعا رح نحكي كمان شوي إنه if the mother is hyperthyroid, okay, and has Graves disease during pregnancy with high TRAB titer, the neonate may develop neonatal Graves disease. رح نحكي عنه بالأخير. وتذكروا إنه سواء كان Graves or Hashimoto's, both of them are higher in females, okay, as the other autoimmune disorders, and the onset is gradual. طبعا sometimes they may present with irritability, with hyperactivity, with emotional disturbances, okay, deterioration in schoolwork, and short attention span. If you examine a patient with hyperthyroidism, طبعا examine for eye manifestations such as exophthalmos, lid lag, and lid retraction. راح أحط لكم eye manifestations بslide later on. They may have tremor, okay, increased appetite despite weight loss, goiter, excessive sweating, muscle weakness, and don't forget vital signs زي tachycardia, palpitations, dyspnea, and may end with heart failure, okay? But hyperthyroidism is very serious, okay? Some may end with heart failure, some may end with arrhythmias, okay, such as atrial fibrillation, if remains untreated. So if you can see exophthalmos, look at the sclera. So usually there is no space between the lower part of the iris. There is no sclera, but here you can see the sclera here under the iris. This is what we call exophthalmos. Lid lag and lid retraction, we usually examine them clinically when we let the patient follow an object that is coming down. So you will see the lid lag and the lid retraction. Here you can see the lid retraction here. Lid lag, which means when the eye is following an object that's coming down, there will be like a lagging of the upper eyelid following the eyeball. زي ما قلنا, sometimes they may have cardiac manifestations. This is very serious, okay? Hypertension, tachycardia, and if you do a bone age, you may have advanced skeletal age بنسميها, أو بنسميه advanced bone age. Okay, يعني الطفل عمره 10 سنين عنده Graves, ممكن تلاقي البون age تبعه 12 years, okay, أو 13 years. هلا بالneonates it's very serious because they may have what we call craniosynostosis, okay. وين أسيل محمد برهم؟
نعم موجودة.
أسيل إيش الكرانيوسينستوسيس؟
إيش هو؟
الكرانيوسينستوسيس هيو قرأته هون في السلايد شايفتيه؟
الكرانيوستوسيس اللي هو
يعني سمعتي فيه قبل هالمرة؟
اللي هو بيكون السوتشرز مش فاتحين.
مش فاتحين؟ ولا بيكونوا فاتحين وبسكروا بسرعة؟
إنه بيكونوا مسكرين بسرعة.
أنت دمجتي الجوابين سوا. مش بيكونوا مسكرين بسرعة. هلا بيكونوا فاتحين، مش sutures at birth they are open. هلا if the neonate develops neonatal gravis that's untreated, they may end with craniosynostosis, which is premature closure of the cranial sutures. Okay? فمش بيكونوا مسكرين بسرعة، هون بيكونوا فاتحين وبسكروا بسرعة. تمام أسيل؟
تمام.
There is what we call thyroid crisis or thyroid storm. It's a severe manifestation of hyperthyroidism with acute onset, and the patient may present with severe hyperthermia, tachycardia, restlessness, heart failure, and they may end in delirium, coma, and death. Okay? فهدول بدهم urgent management. طبعا lab findings كلكم ماخذين باطني، فبتعرفوا الثايرويد فانكشن تيست شو بيكون عندهم. ال T4 وال T3 مسميهم free T4 and free T3 are elevated, but this will cause negative feedback on the TSH, which will be suppressed. Usually the positive antibodies are the trap, the stimulating antibodies. However, they may have positive thyroid peroxidase antibodies. عشان هيك مرات the picture overlaps. Okay? Sometimes you may find normally, يعني حتى الثايرويد antibodies in normal population, in 10% of the population may have positive antibodies. Okay? فعشان هيك it has nothing to do with Graves' disease. Differential diagnosis of hyperthyroidism ذكرنا المكون أولبرايت. المكون أولبرايت it's a syndrome. مكون أولبرايت syndrome. طبعا المين presentation لهم بيجوا peripheral precocious puberty, which is the early manifestations of pubertal أو secondary sexual characteristics. لما نيجي بنفحصهم بنلاقي عندهم بنسميه كافي أولاي سبوت. كافي أولاي سبوت. إكرام. وين إكرام؟ إكرام الزغول. اتفقنا أي واحد ما بيرد غياب، ما حدا يراجعني. إكرام الزغول
موجود.
يا إكرام وين بتشوفي كافي أولاي سبوتس غير بالمكون أولبرايت؟ في محل تاني أخذتوه محاضرات مكون كافي أولاي سبوتس؟ بتعرفي إيش هم الكافي أولاي سبوتس؟
لا دكتورة.
ما بتعرفي إيش الكافي أولاي سبوتس؟ طيب بفرجيكم إياهم في نهاية المحاضرة. هلا أخذتوا أنتوا مع الدكتور رضاب؟ أكيد أخذتوا، يعني أنتوا ما ضلكوش غير يومين محاضرات. ما أخذتوا نيورو؟
دكتورة أخذنا.
مين حدا تاني جاوب؟ اللي رافع أصبعه مين هون رافع؟
أنا هون جاوبت.
يلا احكي واحكي لنا اسمك.
رؤى بريزات، بنشوفها بالنيوروفايبروما تايب 1.
Excellent. So neurofibromatosis type 1 NF1. اوكي بنشوف فيه كافي أولاي سبوتس. Excellent يا رؤى. إذا المكون Albright بنشوف عندهم كمان كافي أولاي سبوت which has different characteristics than neurofibromatosis 1. يعني أخذته بالNF1 بتلاقي عندهم smooth outline of the كافي أولاي سبوت ومالتيبل وإلهم special criteria والسايز تبعهم. هلا بالمكون Albright they have irregular borders, okay, they are usually unilateral, okay, on one half of the body. فإذا شفتوا girl عندها كافي أولاي سبوت جاي ب early or precocious puberty بنسميها. think of مكون Albright syndrome. طبعا بيكون في إشي بنسميه يمكن بكير تعرفوه بس تقرأوه بسنة سادسة بسميه polyosteotic fibrous dysplasia of the bones. ببين بالبون سكان. بس يعني هي الفكرة إنه هدول بيكون عندهم activating mutation in the TSH receptor. فهدول it's non-immune mediated. Okay. هلا other differential diagnosis في شيء بنسميه TSH resistance، فبتلاقي المريض عنده high TSH level بس بتلاقي عنده الفري تي 4 TSH resist generalized thyroid hormone unresponsiveness، فبتلاقي عندهم TSH resistance. لا سوري thyroxine resistance، سوري thyroxine resistance مش TSH resistance. اوكي بالعكس ال TSH resistance بتعمل hypothyroidism. اوكي so thyroxine resistance بيكون عندهم thyroid hormone unresponsiveness. في إشي بنسميه T3 toxicosis، بتلاقي عندهم very high levels of T3 but they usually have suppressed actually TSH. exogenous thyroid hormone. exogenous thyroid hormone كتير بيجونا أطفال خاصة على الطوارئ، بتلاقي الأم ماشية على ثايروكسين وبيجي الطفل بتلاقي بالع 10 حبات ثايروكسين. أوكي exogenous thyroid hormone may cause thyrotoxicosis. أوكي but this is different than Gravis disease. طبعا ما راح ادخل كثير بديتيلز التريتمنت، انتم بسنه خامسه بس مطلوبه منكم بسنه سادسه انه في شيء بنسميه medical therapy for Gravis disease، في شيء بنسميه radioactive iodine ablation، وفي شيء بنسميه thyroidectomy او surgery. اوكي subtotal او حتى مرات total thyroidectomy. هلا الشيء اللي لازم تعرفوا انه في شيء بنسميه anti thyroid medications بنسميه ال PTU او البولي propylthiouracil. اوكي propylthiouracil او البي تي يو، وفي عندنا الميثيمازول او الكاربيمازول حسب وين تشتغلوا. بالاردن عندنا الكاربيمازول، بامريكا عندنا الميثيمازول. فهدول لهم ميكانيزم اوف اكشن تقراوهم لحالكم، بس تذكروا انه البي تي يو we don't use it in pediatrics anymore because it has hepatotoxicity. it has hepatotoxicity. فكل الميديكيشن بنستخدمه بالاطفال حتى بالنيونيت اللي هو الميثيمازول او الكاربيمازول. اوكي بس مهم تعرفوا البي تي يو بيستخدموهم في الادلتس في البريجننسي واللاكتيتنج mothers but in pediatrics we don't use them anymore. وboth of them has toxic and severe reactions. فكتير المرضى اللي تلاقيهم ماشيين على anti thyroid medications we must check their complete blood count because it may cause transient leukopenia or even in severe reactions agranulocytosis. Okay it may cause rash, okay, or hepatotoxicity or SLE-like syndrome, but hepatotoxicity is much less in carbimazole or methimazole, but it's higher in PTU, propylthiouracil. Okay. في عنا بشار. وين بشار؟
عيني دكتورة.
بشار ايش لك ايه granulocytosis؟ عمرك سمعت فيه؟ ايه granulocytosis؟
اللي هي type of anemia that present due to surplus of bone marrow. All of the white PCs will be suppressed.
متأكد هيك الgranulocytosis؟ انت قلت بالاول انيميا، هلا it's
لا
not
لا
anemia.
هي not anemia. yes related to white PCs disorder.
انو الوايت بي سيز مينلي ايه granulocytosis اي واحد فيه؟
الايزينوفيلز والبازوفيلز.
لا بدي الايه granulocytosis يعني لاي part of the white blood cells بتكون له
الجرانيولوسايتس not الليمفوسايت.
تمام اللي هم mainly ايش؟ نيوتروفيل صح؟ mainly نيوتروفيل صح؟ بتلاقي عندهم severe neutropenia، بتلاقي اذا بتعمل تحسب الابسوليوت نيوتروفيل كاونت بتلاقي less than 200. اوكي فالايه granulocytosis اللي هو severe neutropenia. تمام يا بشار؟
اوكي تمام.
Good. Okay. فعشان هيك أي مريض على anti thyroid medication you must do for them regularly complete blood count and liver function test. Okay. And liver function test. وتكمن إن نشوف بيجونا مرات المرضى بيشكوا من rash. One of the side effects. هلا some patients if you stop anti thyroid medication may have relapse within 3 months or 6 months of stopping treatment. Okay. Some patients may be given beta blockers such as propranolol if they have severe cardiac manifestations, severe tachycardia, for example, symptomatic tachycardia such as chest pain, heart failure etc. فممكن هدول يعطوا أو severe tachycardia, chest pain, hypertension, so may be given beta blockers. طبعا مش كل مريض hyperthyroidism نعطيه beta blockers. There's specific indications. When do we proceed for surgery and radioiodine ablation? طبعا definitely when medical treatment fails, okay? For example, it's either severe Graves disease or, for example, poor compliance. We may proceed for either radioiodine or surgery. So radioiodine is not much preferred in pediatrics. We do them in adolescents in severe cases. ليش حدا بيعرف ليش مش كتير بنحب الراديوأيودين بالأطفال؟ أنا مش شايفة حدا بده يجاوب بدون ما يرفع إيده.
الراديو iodine may precipitate to cancers.
صح. So it increases risk of malignancy. Excellent. طبعا في كتير هلا إذا بتفتحوا على الراديو أيودين بتقرأوا articles, you will see إنه some articles says that it does not increase risk of malignancy, while other articles defend that and says no, it increases risk of malignancy. فما بنقدر نقول it does not increase. So it increases risk of malignancy. عشان هيك ما بنحبهم خاصة بالpediatrics. But if there is a severe case of Graves disease, then we may proceed for radioiodine. Okay, so we usually remain on antithyroid medications if it is under control. Next step or other option is surgery. بس بتعرفوا surgery it has its own complications. بتعرفوا complications of surgery, hypopara, thyroidism, vocal cord paralysis, etc. Okay. هلا radioiodine ablation, one of the complications that may occur which is recurrence. أكيد الريكرنس مش للثايرودكتومي، ريكرنس للراديوأيودين. يعني كثير مرضى بينعملهم first time radioiodine then بصير في relapse و recurrence وبنرجع بنعملهم مرة تانية و they may proceed also for surgery. Okay. So radioactive iodine ablation is effective and relatively safe, although there is a risk of oncogenesis and malignancy. And there is risk of future hypothyroidism or recurrence of Graves disease. هلا نحكي سريعا عن congenital hyperthyroidism. It's not very common, but it's still there. إذا بتداوموا خداج رح تشوفوا إنه mothers with Graves disease who has the titer, the TRAB positive or highly positive, you know that TRAB crosses the placenta and may cause neonatal Graves disease. Okay. So congenital hyperthyroidism or neonatal Graves disease, it may present at birth, okay, or sometimes it is noticed few days later. عشان هيك أي بتولد بيجيها baby هي عندها Graves disease, usually we follow up thyroid function test until 7 to 14 days because symptoms may develop later. Usually, mothers in active Graves disease with positive antibodies at higher risk to develop their babies to develop neonatal Graves disease. Okay. So high levels of TRAB, the stimulating TRAB, I mean, in the mothers predict the occurrence of neonatal Graves disease. Sometimes antenatally they may have what we call fetal tachycardia, and sometimes they develop goiter intra-uterine. عشان هيك هدول we proceed for cesarean section لإلهم because normal vaginal delivery is impossible. But you must know that neonatal Graves disease is a transient kind of neonatal hyperthyroidism, okay? But sometimes it may need treatment. So كتير شفنا بيبيات وبلشناهم على antithyroid medications, okay? So just for a kind of symptomatic treatment until self-resolution. They may be like clinical manifestations of neonatal Graves. They may born premature, okay, or IUGR بما انكم هذا دوامته نسائية بنسميه intrauterine growth restriction, or they are born small for their gestational age, بتلاقي وزنه قليل, okay. May have goiter. كتير أطفال ممكن يجوا عندهم restlessness, tachycardia, tremor, hyperactivity, anxious, alert, بتطلع عليهم، تطلع عليهم على عيونهم، بتلاقيهم they are open, widely open. ممكن يكون عندهم microcephaly. Okay, so this is very important. This is due to antenatal presentation of neonatal gravis. Okay, intrauterine. طبعا the highest risk of cardiac decompensation of heart failure is risky in newborns. عشان هيك احنا بنخاف يعني neonatal gravis بنخاف they may develop heart failure and they may die if treatment is not started promptly. طبعا زيه زي أي hyperthyroidism, TSH will be suppressed with elevated free T3 and T4. They may have advanced bone age, craniosynostosis زي ما حكينا, and frontal bossing. So it's unknown regarding the IQ, but usually it's fine. And treatment زي ما اتفقنا mainly anti-thyroid medication, or mainly it's carbimazole, not the other. May be given propranolol in specific cases, beta blockers. Some hospitals have what we call Logol solution, which contains iodine that block the uptake of iodine and the thyroxine metabolism and decrease the production of thyroxine. They may need IV fluids, and in severe cases they may be given steroids, because you know steroids slow down the conversion of T4 to T3. عشان هيك ممكن نعطيهم steroids in severe cases. Okay, and symptomatic management of heart failure. So we will consult cardiology to give them digoxin or whatever for heart failure. Okay. طيب. حدا عنده أي سؤال؟ وين عبد الرحمن خلدون؟ عبد الرحمن خلدون. طيب عبد الرحمن خلدون نادينا عليه مرتين وغياب. اوكي طيب خدوا بريك 5 دقائق، 5 دقائق عشان لبين ما نفتح المحاضرة اللي
بصير
بعدها.
استوضح إشي.
تفضلي يا لينا.
بس شرحتيها أنت بس مش كتير أنا لقطها.
يلا
فكرة
تفضلي.
الديفلوبمنتال والانتلكشوال كيف بصير development سواء الجروث والintellectual ability في الشيلدرن بعد ما نعطيهم التريتمنت لما يكونوا هايبوثايروديزم لأكثر من 6 شهور. حكيت الجروث بيرجع عادي بس الانتلكشوال هو الامبيرد.
صح
يعني
100%
زي
صح.
هيك.
صح
تمام.
يعني بالcongenital hypothyroidism if you delay treatment after the age of 6 months في question mark على الcognitive function والdelayed cognitive development. لما بنحكي cognitive development احنا بنحكي عن السبيتش، عن اللانجوج، عن طبعا، ولما بنحكي عن language احنا بنحكي عن receptive language and expressive language. يعني ممكن تلاقي يتأخروا بالحكي أو يتأخروا بالcomprehension والاستيعاب، يعني ما بيستوعبوا مزبوط، أو later on بيكون عندهم delay بالاي كيو أو low IQ أو حتى بالعمليات الحسابية أو إلى آخره. هلا الجروث أوكي initial stunted، بس مجرد ما أعطيتي ثايروكسين الجروث بتحسن. أوكي بس الانتلكتشوال function it will not improve if you delay treatment. وعادة يفضل التريتمنت قبل الشهر الأول as soon as possible. مجرد ما شخصنا hypothyroidism treat as soon as possible على طول، ما تستنوا. أوكي
دكتور قد ايه الرينج تبع المنتال ريتارديشن اللي بصير؟ يعني هل ممكن عن جد تصير يعني الطفل كتير غبي من هذا
طبعا هلا ما عندي انا رينج، ما عندي يعني ستاديز افرجيكي قديش. اكيد الستاديز موجوده بس انا ما طلعتها يعني، بس اكيد it may be severe intellectual disability. ومنتال ريتارديشن قلنا the most common cause of treatable mental retardation.
اوكي تمام، شكرا دكتور.
ولا يهمك. خاصة يلينا المرضى اللي بيكون عندهم ثايرويد ديسجينيسيس ايجينيسيس او اكتوبيك ثايرويد، اللي بتلاقي عندهم التي اس اتش اول ما بنيجي نقيسه اكثر من 100. انا شفت مريض كان عنده 600 التي اس اتش، فهدول بتلاقي عندهم سيفير هايبوثايروديزم. هلا الديسهرمونوجينيسيس عادة بتلاقي التي اس اتش مش كثير عالية. يعني شفت مريض 70 80 فيوجولي اتس مايلدر ديزيز. وراح تسألوني إنه مين اللي فيهم راح يكون permanent ومين منهم راح يكون transient. هلا أكيد الديسجينيسيس والإكتوبيك والهدول راح يكونوا permanent. راح يسألوكوا الأهل for how long the patient must be treated، فرح تحكوا لهم it's lifelong treatment. هلا مرات المرضى الديسهرمونوجينيسيس او بتلاقي mild hypothyroidism usually we must continue treatment until the age of 3 years until the brain development تقريبا يكتمل. بديش اقول يكتمل تماما بس جزء منه كتير كبير يكتمل او الميلينيشن. هلا مرات شو بنعمل اذا كان mild case بنوقف الثايروكسين على عمر 3 سنين and then we observe، لانهم بعض المرضى كيف بنعرف انهم we may stop thyroxine at the age of 3 years a trial of cessation of thyroxine. بتلاقي المريض مثلا بحاجة low dose of thyroxine، بتلاقي ضل فترة طويلة ماشي على very minimal dose of thyroxine and he didn't need any increment in thyroid dose. فهدول بنشك فيهم ممكن يكونوا dyshormonogenesis. بنوقف التريتمنت على 3 سنين، بنعيد الثايرويد فانكشن تيست كل اسبوعين وبنشوف. بعضهم بيحتاج لاول 3 سنين وبعدين they don't need further treatment، وبعضهم لا they fail the trial وبيكملوا thyroxine lifelong. اوكي هلا ما تنسوا انه بعض المرضى بحاجه ل hearing test لانه it may cause sensorineural hearing loss، فكل مرضى الcongenital hypothyroidism نبعتهم for hearing assessment. اوكي تمام ولا يهمك. هلا 5 minutes بس لبين ما افتح المحاضره الثانيه.